Interventional radiology is a subspecialty of radiology whereby we use minimally invasive techniques and imaging guidance to perform minimally invasive procedures for diagnostic and therapeutic purposes. In relation to oncology, we spend a lot of time, we perform biopsies of virtually every area in the body using imaging guidance to make diagnoses. We perform procedures like chemoembolizations in the liver, where we take advantage of some unique anatomic and physiologic properties of the liver to deliver very aggressive chemotherapeutic agents to certain types of tumors with an excellent result. We use radiofrequency ablation, which is insertion of a probe into tumors in certain parts of the body, the liver, the kidneys, the lung, to destroy tumors in that way, again using minimally invasive techniques guided by imaging. There are several tumors the liver is a frequent area for tumors to spread or arise primarily from hepatocellular carcinoma, also called hepatoma. Carcinoid tumors will often spread only to the liver. Islet cell tumors of the pancreas will often only spread to the liver. These are all tumors that once they have spread to the liver, if they are not resectable surgically, as many of them are not, the single best treatment is hepatic artery chemoembolization. And that's a procedure where we take advantage of the fact that the liver has a unique blood supply and the fact that most of its blood supply is from the portal vein with a small contribution from the hepatic arteries. Tumors have a unique biology whereby virtually all of their blood supply comes from the hepatic artery, and we take advantage of that. We're able to deliver very high doses of chemotherapy that would be toxic if they were given peripherally directly into the tumor with very small, really relatively few side effects, and destroy most of the tumors within the liver. This is done using the guidance of a C-arm and angiograph equipment, very high-tech, very advanced angiographic equipment and catheters and wires to perform this procedure. The patients tolerate it quite well. Generally involves an overnight stay, and probably 80 to 90% of our patients go home the next morning. In most patients, we will destroy over 90% of the tumor in their liver. Unfortunately, we can't cure it, but there's no other treatment that even approaches that for tumor destruction. And if their liver function is adequate, that will, in a lot of patients, suppress the tumor, and they will do quite fine. We will follow them up with CT scans, and if we see evidence of progression of disease, we can go back and do it again. We have several patients, as I said before, whose life expectancy at the time of presentation was probably in the range of 1 year or less, who are 3 to 4 years out, living quality lives without pain and doing quite well, and we continue to follow those patients. Generally, patients are referred to me by one of the Baptist physicians, and the surgeons, oncologists, internists, just about any Baptist physician has at one time or another referred a patient to me for some type of procedure. Depends on what the patient's problem is and what that particular physician's area of specialty is.